We're calling the fourth meeting of the Senate Standing Committee on Health Services to order. Becky, if you would, please call the roll.
Senator Rocky Adams. Senator Berg. Present. Senator Carroll.
Here.
Senator Douglas.
Present.
Senator Herron. Senator Mills.
I'm here.
Senator Nemes.
Present.
Senator Rawlings.
Present.
Senator Tishner. Vice Chair Richardson.
Here.
Chairman Meredith.
Present. We do have a quorum and duly constituted to conduct business. Anyone have any guests they want to recognize this morning? Seeing none, let's get right into the agenda. Going to have flight deviation because we're always pressed for time and don't know how successful we are maintaining a quorum. So let's move to consideration referred administrative regulations. Are any questions on the regulations for anyone? Seeing none, we'll assume that they have been reviewed. Thank you. Back to our former agenda. We'll ask the legendary Senator Gerald Neal to come to the table to discuss Senate Bill 56. Good to see you this morning, Senator.
Good morning, Mr. Chairman, and good morning, committee members. I have with me Billy O'Brien from Young People in Recovery to help with this presentation.
Just a small technicality. I know I introduced you, but please introduce yourself for the record.
Gerald Neal, 33rd Senatorial District,
Thanks, sir.
Senate.
Feel free to proceed.
Thank you, Mr. Chairman. Pain parity legislation is needed to ensure access to novel non-opioid choices. That's what Senate Bill 56 is about. As we know, pain is one of the most common reasons for patients to see a doctor, and there's a high unmet need for safe and effective medicines to treat moderate to severe acute pain. There's an urgent need, in fact. Senate Bill 56 would prohibit the Department of Medicaid Services, any Medicaid managed care organization contracted by the Department and the Medicaid State Pharmacy Benefit Manager from denying coverage for a non-opioid analgesic in favor of opioid analgesic or establishing more restrictive or more extensive utilization controls for non-opioid analgesics than the least restrictive or extensive utilization controls for any opioid or narcotic analgesic. This legislation is straightforward. If a patient and their physician decide a non-opioid option is best for them, when they go to the pharmacy counter, they will not be told to receive the non-opioid. They will have to wait for a prior authorization and or any other medicine first. The legislation ensures non-opioid access is not disadvantaged compared to opioids. Pain parity safeguards equal access to patients with acute pain and levels the playing field by prohibiting the use of prior authorization or step therapy to ensure patients are not disadvantaged when accessing non-opioids. Many short-acting opioids are available without prior authorizations or step therapy. It is imperative we do not place obstacles in place to access non-opioids, our patients will be denied real choice. According to the same Cover My Meds report, 91% of respondents reported that PA results in delayed access to necessary care. In the same survey, 75% of respondents reported that the PA process has led to patients abandoning treatment altogether. Opioids were originally declared a public health emergency by the federal government on October the 26th, 2017, and the declaration has continuously been renewed into 2026. In Medicaid, the cost of opioid use disorder is even greater, as the incidence is estimated to be approximately 10% greater compared to those with commercial insurance. In fact, 5 of every 100 Medicaid beneficiary beneficiary that gets a prescription for acute pain will go on to develop OUD. Those that go on to develop OUD are estimated to cost Medicaid on average nearly $10,000 more in annual health care costs. This bill ensures patients have access to new non-opioid acute pain medicines and ensures patients aren't forced to take opioids due to step therapy or prior authorization practices. Again, Mr. Chairman, I have with me Billy O'Brien, who can speak from personal experience in this particular regard, and also is very much involved with the young people in recovery and could add more to the discussion.
Mr. O'Brien, welcome to our committee meeting, and please share your testimony.
Thank you, Senator Meredith. Good morning, committee members. I'm here today in support of this bill, and as someone in long-term recovery and deeply engaged in advocacy, I've witnessed how our current regulations can unintentionally limit safe non-opiate options for people who actively have substance use disorder. In 2021, I underwent elbow surgery. Despite my physician noting in my file that I did not want opiates, the surgical team attempted to prescribe them. It took persistent advocacy on my part to ensure my recovery plan was respected. Earlier this year, my wife, she's also in long-term recovery, was in a serious car accident and transported to the hospital, into the ER. When she declined opiates, the only alternative offered was over-the-counter medicine. She was in acute pain, and yet the system gave her no viable non-opiate options. She didn't have to wait 2 weeks to wait for a specialist or navigate red tape. She needed compassionate, effective care in that moment. These experiences are not isolated. They reflect a broader issue. Our laws make it easier to prescribe addictive opiates rather than access to safer alternatives. We must empower physicians to offer a full spectrum of pain management options, especially for those in recovery. This is not a matter of policy, it's a matter of dignity, safety, and public health. I urge you to support this legislation that expands access to non-opiate pain treatments and removes unnecessary barriers for providers and patients alike. Let's ensure that Kentucky leads with compassion and evidence-based care. And I want to thank you all for your time and allow me to testify this morning.
Appreciate your testimony. Whenever we hear firsthand about these incidents, it brings so much more value to discussion on these proposed bills, so I appreciate that. Senator Douglas.
Thank you, Mr. Chairman. Excuse me. Senator Neal, one of the questions I have is we have some issues with multiple medications that people get started on, whether it's in the acute pain setting or some other time. How best? Because I know this is really a provider preference issue when it comes to how and what we treat our patients and what we treat our patients with. Has there been any thought about the addition when people will add them, use non-opiates and opiates together, because that, when we use those two, it tends to defeat the purpose of the non-opiate. Has there been much discussion or have you had much talk with anyone about using the non-opiates in isolation and not in combination with opiates for pain relief?
Personally, I have not. Okay. Not sure I could speak to that. Perhaps my guess.
I mean, for me, I think that it was just being able to have that option. For me, the experience was a surgical team from the moment I walked in the office until I was being put under anesthesia was trying to prescribe me opiates, and it clearly stated that I didn't want them. And there was no option at the time. This was a couple years ago. Now we've got the medication, that's available, and with the red tape around the Medicaid, it's going to be harder for somebody in long-term recovery or it's early recovery that doesn't want to take a chance of going back and having a reoccurrence of use because of overprescribed medication. So just being able to have that option to be able to get a non-opioid for a short time to help deal with acute pain.
Okay. May I ask one more question, Mr. Chairman?
Yes, please.
Thank you. I just want to inform folks, having been in this particular space for almost 30 years, one of the reasons that physicians have chosen to use opiates instead of non-opiates really came from the feds. The problem, and our pharmaceutical companies, the problem was that the cost of non-opiates were so much greater than the cost of the opiates. So, you know, as just like gravity or water, it seeks the area of lowest resistance. So many of our healthcare providers chose opiates, even though they wanted to choose non-opiates, but it was just cost-wise was unavailable to our patients. And so I talked to Senator Neal a little bit earlier last year, and I'm glad he's brought this back. I've had a little bit more time to do a little bit more research, and so I feel more comfortable with this bill, Mr. Chairman.
There's a motion, a second on the bill. Any further discussion? Seeing none. All those in favor vote aye. All opposed vote no. Clerk, please call the roll.
Senator Rocky Adams, Senator Berg,
Aye.
Senator Carroll,
Aye.
Senator Douglas,
Aye.
Senator Herron, Senator Mills,
Aye.
Senator Nemus,
Aye.
Senator Rawlings,
Aye.
Senator Richardson,
Aye.
Senator Tishner, Chairman Meredith.
Aye. Vote is 10 ayes, no noes. The bill passes with favorable expression. Congratulations, Senator. Look forward to hearing this on the Senate floor.
Thank you, Mr.
Mr.
Chairman.
Brown,
and
thank you for being here
members.
today. Appreciate you participating. Our next bill on our agenda is Senate Bill 72. Senator Douglas, if you would. You certainly know the routine. If you would, introduce yourself and your guests for the record, and feel free to proceed.
Thank you, Mr. Chair. Thank you, Mr. Chairman. State Senator Don Douglas, District 22. I'll let my guest introduce himself.
Greg Chaffwin, Senior Legal Counsel with Alliance Defending Freedom.
Mr. Chairman, it is always a pleasure for me to come before this committee. We have some really deep thinkers in the committee and members of the Senate who really listen. So I'd like to say good morning, Mr. Chairman. Good morning, Mr. Vice Chair, and members of the Health Services Committee. Senate Bill 72 is really a common sense bill, and all we're looking for is parity for professionals. I'm sure some of you all have received some text, you've received some emails, you've even received some phone calls regarding Senate Bill 72 that really suggest fear. Please let me clean up some of the misperceptions by telling you what this bill is not, and by clarifying accurately what this bill truly does. This bill is not a challenge to the social structure. It is not a free ticket to treat people differently, but it's just the opposite. It is not an activist bill to be used in the very rare occasion or the instance that someone might not wish to fulfill their work duties in the healthcare space or for any other job. We have hardworking, dedicated people who are citizens of our country, but we also have less hardworking, less dedicated people in our country. We can't legislate the difference, even if we try. So what is this bill? This bill is a provider recruitment and retention tool. It's an economic development tool, and it is a tool that says to a healthcare provider who wants to come into our Commonwealth that we welcome you for your dedication and your hard work for serving the public. Even though we're going to continue to expect the highest level of professionalism from you, we will honor your individuality as a person and your values just like we do everybody else in the Commonwealth of Kentucky. You know, there's no question that we have a healthcare provider shortage, and no question that we have a location maldistribution problem of our physicians. So we do have healthcare deserts. You know, just these factors alone are really extending the wait times for our consumers to see their doctors, their nurses, get laboratories, or even get procedures done. The pressure on the healthcare workers are great, and they get even more magnified when someone is in a practice or a situation where they hear these words. If you don't do as I ask, even if you don't agree, there will be consequences. And there may be some in the healthcare space who haven't heard that, but there are many more in the healthcare space who have heard that. They just don't share it. You know, these words make practicing medicine even more challenging. And this bill, what this bill is meant to do is take away some of the fear from our highly trained professionals who are employed in other areas, and it adds some accountability to those employers who employ them this way. You know, we don't say that the fear is okay when we do this in a banking situation or for an assembly line worker or a construction worker or even those who are receiving public assistance. Some healthcare workers may even choose to accept the challenges to their beliefs out of fear that they'll lose their job. And that's their choice. I don't have a problem with that. It is their choice. But you know, this bill protects those who wish to follow their strongly held conscious beliefs, as long as it does not put others in danger or even interfere with the rights of others. There are always other healthcare providers that they can use as options that the patient can seek. And after all, no patient wants a healthcare worker, especially a physician, to do something they're not comfortable doing or do something that they're not trained to do. You know, we're likely to continue to see a dwindling number of physicians in general, and especially a dwindling number of specialists in medicine, most likely because of the work environment that has been changing over the last decade, or the loss of independent thinking, the loss of independent decision making that we physicians have enjoyed or had enjoyed for a long, long time, and then the time constraints, having to see more patients in a shorter period of time because of cuts in reimbursement. Yeah, that happens in medicine as well. The other thing that has cropped up, Mr. Chairman, is corporate medicine and some other forms of medical practice. And they have even introduced a new dynamic into practice pressures. You see, in traditional private practice clinics, cash flow is still needed. It's still needed. But I would argue that patient care, good patient care, was truly the end product. That's what we strive for. And this is not a criticism, but let's look at this objectively. Most corporate medicine clinics, they truly have a different business model. And I say this being in medicine. This business model involves investors, not a dirty word, but investors. And these investors are looking for a return on investment, whether you like it, whether you want to accept it or not. Many people don't wish to speak of this, but this must be and is a consideration of those who work in those clinics. They want to keep their jobs as well. You know, I can tell you stories that my colleagues have shared with me regarding some of the pressures that they felt in these type practices. I can even tell you stories that my 3 kids, I guess I still call them kids, who are practicing specialty medicine in other states, still share with me about some of the things they have to deal with. This is not the medical environment that we had 2 decades ago. It is not. You know, there are those who have suggested that there are protections at the federal level. And in fact, I've got a letter, and what that letter said that was sent to me says, there are well-established federal and state laws, regulations, policies, and procedures, as well as policies and medical licensing boards, medical professional associations, and hospitals that guide what is acceptable, what is an acceptable standard. Really? 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 We have those things. We have some of those things. But you know, the federal protections only serve to withhold money from those institutions or those providers until the issue is corrected. The protections, they don't provide adequate civil remedy to those who have been harmed. And that is what this bill is about. Read the federal regulations. Sit down and read the federal regulations. You know, remember that healthcare providers, they see their jobs as a profession. They're highly trained. They spend a lot of nights without sleep. They learn a lot of information. They're highly disciplined, and they're highly dedicated. We're not construction workers, folks, and that's not a knock on the construction worker. But we're not, because most of the decisions that we make are really critical decisions. We don't have the luxury of being wrong. We just don't. They see their jobs as professionals, and their responsibility is very different from those who look at it from the outside, who don't understand the pressures that even linger when you leave the hospital, or even linger when you leave your office. And you're thinking, well, maybe I could have used this drug. Or did they really tell me everything was going on? And if they didn't, did I make that right decision? But I try to make the right decision based on what's there. I encourage every member of the committee to vote yes. And no, this is not a perfect bill, but it is a good framework. And you know, we can't legislate against a stereotype that someone is fearful of. There are, I remember some of my family members as I was growing up not wanting to go into certain businesses or not wanting to go into certain places because, well, black people weren't welcome, they said. We shouldn't go in there. Well, you know what? I went in there, met some of the nicest people I've ever known in my life. In my life. So we should not legislate against the fears. If someone doesn't want something and they fear this might happen, it's not our job to legislate against their fears, their personal fears. I'm not saying that they don't have some experiences to back it up, but that's not our job as legislators. I have someone here who will help me answer questions. Should you all have any questions about this bill, I'm happy to answer them. And thank you for allowing me to speak, Mr. Chairman.
Well, thank you, Senator. And we've got several people who have signed up to speak either in favor or against this bill. To that end, I'm going to ask you gentlemen to step away from the table and bear with me just a second while we figure out what the plan of action here is, because we always endeavor to start on time and end this meeting on time, and I guarantee we will end this meeting on time. To that end, everyone who has signed up, again, we'll try to accommodate to the best of our ability. Going to try to cut this off so we still have opportunity for our committee members to ask questions. So to that end, we ask you to come to the table very quickly and we'll limit comments to 2 minutes. And please, as you listen to questions or testimony from other folks, let's not be repetitive. It doesn't help to hear the same message 15 times. And I'd ask that you do it in a very respectful manner. There's always seems to be a lot of emotion surrounding this bill. So again, I'm going to just caution you, no inflammatory statements. Please speak to the bill. And with that, first to come to the table is Reverend Todd Smith and Reverend Kent Gilbert. If you would, please come to the table. Again, gentlemen, you'll have 2 minutes once you identify yourself for the record.
Thank you, Mr. Chair.
Make sure your mic is on. The light has to be lit. Green.
Sorry about that. Thank
That's
you, Mr. Chair. My name is Reverend James Todd Smith, and I am the chair of the Justice and Advocacy Commission of the Kentucky Council of Churches. Go ahead.
And my name is Kent Gilbert. I'm also a member of the Kentucky Council of Churches Justice and Advocacy Commission and representing Union Church in Berea, Kentucky.
Thank you. Please proceed.
I bring to you today a statement from the Kentucky Council of Churches, Hate is Not the Way statement. Quote, an area of great contention among lawmakers and a source of violence for many has been the legitimacy of medical access. We specifically condemn any legal effort to deprive individuals, particularly but not limited to LGBTQIA plus persons, of the medical care that they and their chosen qualified physicians deem necessary. We condemn the use of religious perspective, whatever the source, being applied in law without regard to scientific consultation and evidence-based outcomes. We affirm the right of religious leaders and individuals to form and follow their own discernment on these matters and promote those views publicly. But depriving others of rights and safety without consent or imposing religious viewpoints with the force of law is in direct opposition of the actions of Jesus. The God we serve is mighty, who shows no partiality nor takes a bribe. He executes justice for the orphan and the widow and loves the stranger, giving them food and clothing. In the face of human divisions, we choose to be guided by this impartial love, which is not the property of any one nation, denomination, or party, but the gift of God to all creation. Close quote. Senate Bill 72 falls into all of the traps of privilege being veiled as a protection of rights. It feigns to protect the rights of practitioners without taking into account the rights of patients who are vulnerable due to their medical needs, likely doubly vulnerable due to their identity. Evidence clearly shows us members of historically oppressed groups already suffer from far worse health outcomes than their cohorts from non-oppressed groups. We must not ensconce this oppression in the law. Please vote no.
Thank you.
Thank you.
Reverend, please proceed.
Thank you. Senator Douglas's fears that we might have a chilling effect, I think are justified. What we have on the books is not always what happens in practice, but that's exactly my concern with Senate Bill 72, which is that while it, as we said, purports to provide protection for some, it does so at the expense of others. We do not feel that religion should be used to generate bias. I don't think anybody here does. I don't think we want religion's perspectives to be used to withhold care. However, this bill would in fact shift the protections of patients to become the protections of providers. And religiously held discrimination, or shall we say sincerely held religious beliefs, is a notoriously inaccurate, hard to govern, difficult to discern method. It really does open the door to anyone saying, I don't want to because I don't want to. And now you've provided through 772 a number of remedies for that person, taking those remedies away from the patient. More than 100 counties have very few providers. So when Senator Douglas mentioned that, in fact, everybody can have their choice to just go to somebody else, that is not the case in an emergency room situation. It is not the case with many opportunities in counties that we represent, that you are from. So on behalf of all, we would invite you to vote no on this bill. It is not a perfect bill. The senator is correct. It is not a perfect bill. It should not advance. Thank you for your time.
Thank you. Appreciate your testimony. Next on our list is Jax Giles, excuse me. Welcome to our committee meeting. If you would, please make sure your green light is on. And if you would, introduce yourself for the record.
Hello, my name is
I don't believe your mic is on. Hit the green button.
Hello, my name is Dr. Jack Skillis, and I'm a licensed clinical psychologist and executive director of an outpatient mental health practice serving patients in Louisville and across Kentucky. Thank you, Chair Meredith and members of the Health Services Committee for the opportunity to testify in opposition of SB 72. Over my 20 plus years of practice, I've heard countless stories of patients who've experienced prejudice and discrimination during healthcare visits. The harm goes deeper than an instance of denied or inadequate treatment. It elevates anxiety and avoidance of healthcare settings that can exacerbate illness and prevent life-saving treatment. Seeking medical and behavioral health services is a vulnerable act. How people are treated in their most vulnerable moments often has a lifelong impact. My stance on this bill is based on the following. 1. There's an inherent power difference between a provider and patient due to where the vulnerability and authority are held. When a power difference is present, the greatest protections should protect those with less power. 3. Religious and moral beliefs are personal and are not a necessary component of a healthcare service and therefore can remain intact when providing healthcare services. While incongruence between provider and patient worldviews may be uncomfortable, discomfort does not change the power differential. When the focus is centered on the work at hand, strictly in the context of healthcare service, it is clear that performing our jobs to the best of our ability means providing quality healthcare to all, with dignity and respect. This is values alignment for our profession and in the healthcare setting. I'm also an active member of the Kentucky Psychological Association, and I was asked to share the organization's strong opposition to SB 72. On the premise that licensed providers of all types accept a certain responsibility to the public, that is why this legislative body creates licensure boards to regulate our practice. To allow some providers to abdicate this professional responsibility is a disservice to those who work so hard to uphold it. I strongly urge you to vote no on this bill. Thank you.
Thank you. 2 minutes exactly. That's incredible. I'm impressed. David Conway. Now, the standard's been set already to finish in 2 minutes. Just see if you can do the same thing. If you would, make sure the green light is on your microphone and introduce yourself for the record. Feel free to proceed.
My name's David Conway. I'm an ordained minister and a registered nurse. Thank you for giving me the opportunity to express my concerns and opposition to Senate Bill 72. This is a difficult story, short, but I'm going to share it with you. It took 3 ER visits, and 20 hours before a hospital admitted Nevaeh Crane, an 18-year young woman, as her condition worsened. Her mom pleaded with the staff to do something to help her pregnant daughter. Nevaeh Crane was crying in pain, too weak to walk, blood staining her thighs. Feverish and vomiting the day of her baby shower, the 18-year young woman had gone to 2 different emergency rooms within 12 hours, returning home each time worse than before. On her 3rd hospital visit, an obstetrician insisted on 2 ultrasounds to confirm fetal demise, a nurse wrote in the notes. By then, more than 2 hours after her arrival, Crane's blood pressure had plummeted, and a nurse noted her lips were blue and dusky. Her organs began failing. Hours later, Nevaeh was dead. In my experience as a nurse, the scope of Senate Bill 72 is overly broad. Any health care worker, including those not directly involved in a medical procedure, receptionists, ambulance drivers, pharmacists, for example, could refuse to care for a patient. This places patients in an unfair situation. The American Congress of Obstetricians and Gynecologists and the AMA oppose this bill. A second problem with the bill is no provisions are made to protect patients who are denied care. This opens the door for delays, leading to additional suffering, even harm, as happened in Nevaeh's case. Senate Bill 72 is confusing. It makes it illegal to even suggest that an employee who objects to providing care can be reassigned to another task. If a nurse or a doctor or a staff member is uncomfortable providing medical care, the compassionate activity is to reassign them. As a nurse and a minister, not offering another assignment violates the ethical and religious freedom.
Thank you. Time is up.
Perfect timing. Thank you very much.
Kind of. Actually, 4 seconds over, but I'll look the other
Not
way.
too bad. Thank you.
Bridget Pitlock. Make sure your green light is on your microphone. If you would, please introduce yourself for the record and proceed.
Yes. Hi, my name is Bridget Pitcock, and I'm a nurse practitioner here in Kentucky. Chairperson Meredith and members of the committee, thank you for the opportunity to testify today. I'm a nurse practitioner providing care here in Kentucky where my work focuses on HIV treatment and prevention. I'm here today in opposition to Senate Bill 72 because it creates a framework that allows medical discrimination and places patient safety at risk. Every day I care for patients from all walks of life seeking time-sensitive care. Many are already navigating stigma and fear. My role is to provide a welcoming space where patients can be honest about who they are and what they need and meet that fear with evidence-based care, not personal beliefs. Senate Bill 72 would make that fear worse. By allowing healthcare workers to refuse care or information based on personal ideology, this bill creates uncertainty at every step of the healthcare process by any healthcare worker. Delayed or denied care can result in preventable harm. Delays don't just affect one person, they have lifelong consequences and public health implications. As healthcare providers, we take an oath to do no harm. That oath does not change based on who the patient is or what someone believes. Religious and political beliefs do not belong in the exam room. When belief overrides evidence, patients are the ones who suffer. I am also a member of the LGBT community, and this bill scares me. Not just of being denied care, but of receiving care that is less complete, less compassionate, and less safe. Senate Bill 72 undermines trust, worsens stigma, and puts patients at risk. If passed, this bill will cause real harm, and I urge you to oppose this bill and protect health care for all Kentuckians. Thank you.
Thank you. Appreciate your testimony. Jackie McGranahan. Hope I get that right. Close. Welcome to the table. Make sure the green light is on. Introduce yourself for the record. Feel free to proceed.
Thank you, Chairman Meredith and members of the Health Services Committee. Thank you for the opportunity to testify today. My name is Jackie McGranahan, and I am the Senior Policy Strategist for the ACLU of Kentucky. I am here to speak in opposition to Senate Bill 72. Senate Bill 72 creates a broad right to any healthcare professional or healthcare institution to refuse to provide a healthcare service that violates their conscience, which the bill defines as sincerely held religious, moral, or ethical principles. The bill also provides that a healthcare professional or institution is not subject to civil, criminal, or administrative liability for exercising this right. The scope of the bill is very broad. The definitions of healthcare professional in Senate Bill 72 include many individuals other than doctors and nurses. It explicitly includes hospital employees, clinic employees, nursing home employees, pharmacists, pharmacy techs, employees, counselors, social workers, students in healthcare training programs, and it also defines participate in a healthcare service very broadly. I grew up in Appalachia, and I understand that despite the chairman's intensive work for healthcare access for rural communities, we still struggle and healthcare access is limited. And I am thankful that we're working on a solution for this. But I'm concerned that this bill will further limit access for some. I was a child of the 80s during the height of the AIDS crisis. One of my mother's coworkers at a hair salon contracted HIV, and I watched how quickly things changed. People whispered, people stopped coming into the salon, others refused to sit in the chair. Fear and misinformation took over, often driven by moral judgment other than medical facts. And Senator Douglas said it best, we cannot legislate fear.
Thank you. Time's up. Sorry.
That's okay. Thank you.
Chris Hartman.
Mr. Chairman, thank you very much. Chris Hartman, Executive Director of the Fairness Campaign. Mr. Chairman, Mr. Vice Chair, members of the committee, thank you for your time. Just a reminder that Senate Bill 72 would allow any worker in a healthcare setting to deny services or to refuse to perform key aspects of their job for any reason, including prejudice, without repercussion if they can justify it as not just a sincerely held religious belief, but also a moral belief or an ethical belief, which could be literally anything. I've sent you a packet last night that includes the reminder that we polled on this not terribly long ago. 3/4 of Kentuckians oppose measures like Senate Bill 72. The definition of healthcare professional is so broad that it applies to not just doctors and nurses, but pharmacists, ambulance drivers, dietitians, receptionists, even janitorial staff. The list of healthcare services that can be denied is so broad, and it's not an exhaustive list, but it includes testing, diagnosis, referral, even record keeping. A receptionist could refuse to check in a patient wearing a MAGA hat. A custodian could refuse to clean an interracial couple's room in the maternity ward, or an unmarried mother, single mother. A pharmacist could refuse to provide HIV prevention drugs. A nutritionist could refuse to serve a gay patient. And they could sue the hospital if they get moved to a different shift or if any disciplinary action is taken. I'll also end by reminding you that if abortion is your main concern, there is already an exemption in Kentucky statute under 311.800. Please oppose Senate Bill 72. Thank you, Mr. Chairman.
Thank you. Tamara Weeder.
Hello.
Please introduce yourself for the record and make sure your green light is on.
Hello, Chairman Meredith. Thank you for allowing me to speak. My name is Tamara Weeder. I'm the Kentucky State Director for Planned Parenthood Alliance Advocates. And on behalf of Planned Parenthood Alliance Advocates, I'm here today to voice our strong opposition to Senate Bill 72. When healthcare providers are allowed to deny care and information, patients are put at risk. This bill allows delayed and substandard medical care with no protections to ensure patients get the care they need. This will harm Kentuckians, especially people who already face barriers to accessing care, such as people with low income or people living in rural areas who can't easily obtain care elsewhere. All people in Kentucky should be able to access the care they need when they need it without fear that their provider will withhold evidence-based care or information. But like Chris said, this bill is so broad that any person who participates in any healthcare service in any way could object for essentially any reason. This bill allows people and institutions to deny care based on their objection to the patient themselves, such as denying contraceptives to an unmarried woman or refusing to provide pediatric care to a child with gay or lesbian parents. Healthcare entities should not be able to pick and choose who gets to receive critical medical care based on personal or religious beliefs. Freedom of religion is important, but religious freedom does not include the right to harm and discriminate against others. Moral objections of healthcare providers cannot be prioritized over patients receiving the care they need. Leaders in the healthcare field, such as the American Medical Association and the American Congress of Obstetricians and Gynecologists, oppose this type of legislation because healthcare providers have a duty to prioritize their patients' interests and well-being. Senate Bill 72 is detrimental to our state and, most importantly, to the people of Kentucky. Please vote no on Senate Bill 72.
Thank you. We have two other people that have signed up to testify, but unfortunately, we have run out of time for this segment because I still need to reserve some time for committee members. So, Ms. Hancock, Ms. Curtis, my apologies, but we need to allow Senator Douglas to come back to the table. If you would, Senator, I'll give you 2 minutes to to give a summation. Then we'll entertain questions from the committee members. 2 minutes, please.
Thank you, Mr. Chairman. Mr. Chairman, excuse me. I really appreciate the passion that's been brought to this table here. And I wish this passion was used to help alleviate the fears. You know, one of the things I've got to say is I'm trying to figure out where the stigma and the fear about our professionals come from. It didn't originate in the healthcare community. It originated with the changes in our society. It originated from the psychosocial changes that occurred in our society. But why do we want to beat up on people in the healthcare system and blame them for it? Say, you're going to do this. You're going to do all these things that people are doing in society. So you don't have the rights that we have. I'm tired of this, Mr. Chairman. I'm tired of us taking our most highly trained, our most intelligent, our most dedicated people and telling them that you don't have proper morals, which is what we're telling them. And we're also telling them that my morals trump yours because I wouldn't do the things that you're going to do. With all due respect, Mr. Chairman, that's unacceptable. The bill does not affect the emergency room. Anybody who clearly reads the bill will look on page 1, line 22. Not going into that any further. And as far as the oppression and all of these things about health care, understand that 70% of patient outcomes is because of patient noncompliance. So we look at oppressed and not oppressed, and we get all these fearful words out there that are actually meant to scare people. The reason we don't have better outcomes in medicine among groups has simply to do with patient compliance, 70% of the time. So please don't let the emotion change your objectivity.
Thank you, Senator. It's 2 minutes. We need to move on to questions. We have 2 people who've signed up so far. Senator Berg, again, ask your questions. Let's try to limit the discussion to a couple of minutes so that we can be on time. So please proceed.
Thank you, sir.
Your mic's not on.
Thank you, Mr. Chairman. I have 2 questions. I will ask them at the same time. Which healthcare organizations in the state, like the Kentucky Hospital Association, the Kentucky Medical Association, the AMA, which healthcare organizations in the state have requested this legislation? My second question, because, sir, we have been practicing medicine at about the same period of time. And I'm driving up here and I'm trying to think, when would this have ever had any applicability to my practice and to my practice of medicine? So could you give me 3 examples of when this bill would be useful?
Senator, how about 1 example? We're certainly running short
One
of time.
example, and who asked for it? 2 examples. 2 examples will
First of all,
compromise.
Senator Berg, this may not affect your practice. It may not affect your practice. We don't do legislation just for your practice. We do legislation for the people of the Commonwealth of Kentucky and for those who serve here in the Commonwealth of Kentucky. And there are a lot of practices that this will affect, but it may not affect your practice. One example, having prescriptions changed. I've been in clinics where the owners of the clinics actually changed prescriptions that were written for patients. I can give you more, but the chairman asked me to give you 1.
Thank you. Appreciate that. Senator Rawlings.
Excuse me, sir. I did ask which medical societies in the state have requested this legislation.
We act based on what we see as legislators. We also act based on what the information that we get from our constituents and others.
So the answer is none.
I'm not sure that would be the answer.
Who?
Is it necessary to have those organizations request information or request this type of legislation? Do we legislate for specific groups or do we legislate for the masses? One of the things I always argue is that one of the problems we have in the legislative process is that we legislate for exceptions and then we can't afford it. What I think we ought to do as legislators, and I've said this before, I've said this while sitting up here, we should legislate for the masses and then we should do amendments for the exceptions so that we adequately cover those who need to be covered with exception.
Sir,
Thank
you have
Thank
clearly
you.
stated.
Senator, it's time to move on. He answered the question, and I'm going to caution Senator Douglas as well. Let's answer the questions. We don't need to pontificate on all these other matters. So, Senator Rawlings, you're next in the queue.
Thank you, Mr. Chairman. I was able to speak with a medical school student from UK, and he and his wife both were attending UK, and they were sincerely concerned about their conscience rights to the extent that they were going to move to Florida, where they do have conscience protections. So this bill I don't see this as withholding care type of bill. This is about recruiting doctors and upholding their conscience rights. So, Senator Douglas, the Constitution of the Commonwealth of Kentucky, Section 5, the final sentence says, "No human authority shall, in any case whatever, control or interfere with the rights of conscience." Don't you think that there was a lot of thought put into that last sentence of Section 5? And doesn't this legislation fit hand in glove with our constitutional rights?
Thank you, Senator Rollins. It does.
Thank you.
Thank you.
Senator Herron.
Thank you, Mr. Chair. I don't have a question. I just want to speak on this piece of legislation and just talk to the committee. You know, this session already, we have passed 2 pieces of legislation that assist in expanding our rural health care. We talked about how there's individuals in the state who don't have access to health care. And if you all remember, I actually changed the vote on the floor to ensure to make sure that people across Kentucky, more specifically rural Kentucky, had access. And I just want to make clear that this bill basically is going against what we've already done this year, is that we cannot in one breath say that we want to expand healthcare and make sure all Kentuckians have that access, but then create pieces of legislation like this that would then create barriers and allow some people to be excluded. And so I will be a no today, and I encourage my colleagues to do the same.
Thanks, Senator. Appreciate that. Motion on the bill, is there a second? Motion is second. All those in favor vote aye. All opposed vote no. And if you feel compelled to explain your vote, please keep it to a minute or less. We'll have that opportunity again if it advances to do that on the full Senate floor. So again, all in favor vote aye. All opposed vote no. Clerk, please call the roll.
Senator Rocky Adams. Senator Berg.
Explain my no vote, please.
If you must, but be brief.
I must. You know, I was raised by a surgeon who was born in 1918, and he indoctrinated in me at a very young age that physicians, healthcare providers, you never want to know who is the perpetrator and who is the victim, because it may unconsciously influence how you treat that person. And our job is not to judge. Our job is to heal. Our job is to treat and not make moral judgments on who we are treating or why they are in that situation. I find this bill antithetical to established medical ethics. Thank you.
Senator Carroll. Senator Douglas.
Aye.
Senator Herron. Senator Mills.
Explain my vote.
Briefly.
I will. Mr. Chairman, I thank you for hearing this bill today. I think Senator Douglas hit on this. This is a recruitment tool. I find it interesting to note that Ohio, Tennessee, and Illinois both provide for this protection for medical professionals. I know in this committee, I know I'm new, I'm not a doctor, but I hear this year and last year the talk of lack of doctors, the tough recruiting process of getting a doctor to come to Kentucky. I think this provides for safety to keep our medical professionals in Kentucky and allow them to continue to practice. Thank you.
Senator Nemes.
Explain my vote, please. Yes. The way I see this is an aye vote. The way I see this is not denying patients of whatever persuasion any care, especially in emergency, that they will get care in emergency. This does exempt medical people from going against their morals in non-emergency, non-life-threatening procedures that they morally disagree with. I vote aye.
Senator Rawlings.
Aye. Aye.
Senator Richardson.
Aye.
Senator Tishner. Aye. Chairman Meredith.
Aye.
Mr. Chairman.
Senator Carroll.
Mr. Chairman, I'd like to cast an aye vote and explain, please. I struggle with the fact that I've not received one phone call from any physician in my district. I struggle with the fact that KMA, AMA has not come out in support of this. And in legislation that we pass that deals with specific professions, we normally go with what those professions ask for. And we usually support those things, or at least I do. And in this case, I struggle with this. And it's not that I disagree with the moral connotations of this. I do not like an ideology that I disagree with being forced on me in any manner, or my children, or my family, or anyone else for that matter. There is a basic right to care that I agree with. I think maybe a narrowing of this bill would be in order to address maybe elective procedures of that nature that could conflict. Something that would be more specific might be in order. But Mr. Chairman, I welcome the discussion that I'm sure we will have as we move forward on this, and I will be a yes vote for now.
Thank you, Senator. The vote is 8-2. It passes with favorable expression. Senator, congratulations. Move forward. Look forward to continued discussion in our caucus meetings and on the floor. With that, no further business. We stand adjourned. But just a reminder, our next meeting will be February 18th, again at 8 o'clock a.m. Thank you. We stand adjourned.